Yes, Dr. Bandyk.
Mo, can you hear me okay?
Yes, sir.
Excellent. Thanks for being here. And you can see my screen?
Yes, sir.
Even better. We'll just wait. Thank you.
Gavin. Gavin? Gavin. With the title.
How many do we have? I can't see
Yeah,
the.
we have a quorum now, Mark. If you are ready, we could
Oh,
start.
good.
Okay.
Thank you.
Thank
Well,
you.
good morning. Hi, Mark Bandyk. Um, I have the opportunity to take care of bladder cancer here, and it's been great, and it's a challenge, and we enjoy it. I'm going to speak this morning about evolution of muscle-invasive bladder cancer therapy over the last few decades, and I have no disclosures. Over the past recently, decades, there's been a evolution and refinements in the perioperative management and operative techniques. Now, we've been performing a few radical cystectomies, urinary diversions, so your residents are understanding the commitment that the patients must make in having treatment for their muscle-invasive bladder cancer this way. Over the last few decades, there's been an evolution, and we've been using robotic-assisted radical cystectomies. There have been enhanced postoperative recovery programs, ERAS programs that have been developed. Um, so we're going to really talk about that, but then over the last recently, we've incorporated more systemic therapeutic interventions, and we've used the neoadjuvant chemotherapy and also immune checkpoint inhibitors. And so in this talk, I'm going to talk about the principles of systemic therapy. And you see in this NCCN guideline picture, a chart, neoadjuvant chemotherapy, perioperative sandwich therapy, and adjuvant therapy. So I'm going to really explain where and why we've inserted this systemic therapy into this whole management of muscle-invasive bladder cancer. I'm starting out with this. Really, the story begins in 2001. And you've seen this article pop up, Dr. Stein's article, but it's really Don Skinner's from USC, his radical cystectomy surgical series. And this paper really established the benchmarks for stage stratified reoccurrence risk and survival after a radical cystectomy. This publication is important. It's one to have in your publications because it's really set the standard for the outcome probabilities and prognosis following cystectomy. And we found that pathologic stage is the most important predictor of outcomes following a radical cystectomy. So if you look at this entire cohort of 1,054, what I'm really using recurrence-free survival and overall survival are the two metrics that really been used to evaluate cystectomy and also systemic therapy, as you will see. You know, recurrence-free survival is the time interval. If somebody could stay unmuted, that'd be great. Thank you. Recurrence-free survival is the time interval from an event, either like the diagnosis, in this case, surgery, until the cancer reoccurs or the patient dies. And if you look at this series, overall recurrence-free survival at 5 years is 68%, and at 10 years, 66%. So, stop and what does this mean? That after undergoing this really morbid surgery, change of quality of life surgery, the sacrifice that's been made, even at 5 years, a third of people have recurrent disease coming back again, or even mortality from their bladder cancer. And same thing for 10 years. So it's quite startling. You have to stop and take a look at this. But again, this was 25 years ago. If you look at the organ-confined muscle-invasive P2, this stage is 89% and 87% recurrence-free survival. The P3As are 78 and 76%. The real problem, though, is that, and I want to really focus on these non-organ confined muscle-invasive bladder cancers, nodes negative, the P3Bs and the P4s. See, that's like only a third, 2/3 of them are do not have this reoccurrence. And at P4s, half of the people have recurrent cancer coming back in, or even mortalities. And so we keep this in mind because this is where this paper, and you'll see later, where we're going to do some work with these people and help them. And this is where we're going to insert other therapies, the systemic therapies, into the management. The P positive lymph node involvement, 24% in this through recurrence-free survival, is really just a third of them. This is significantly lower than for patients without lymph node involvement. So you've seen these charts on the probability of it not reoccurring. This is important to look at this. This is now looking at overall survival by path. Look at the top line, organ-confined disease at 5 years. Even when you think that you have the cancer within the bladder and it's removed, there's at least 25% have lost their lives afterwards. And so you've gone through this, and at 5 years, it's still coming back, or maybe you lose your life with this series. So it just shows you the problems that we need to focus on. But now this is chapter 2 of this series, and this is a paper that I found, and it's an update from USC where they added on to their cases. Now this was published in 2022, and now it's looking at 3,347 cases. So it's an update of the USC experience, and that's where we're going to now see how well do they do, 20 years later at USC, which is a high volume academic center. So this is an update of the USC experience of 3,347 patients. After a radical cystectomy, outcomes during developments in management at a high volume academic center. And so what we're going to do is make some comparisons between the historical and contemporary USC experience afterwards, and also make comparisons with other programs too. In the USC contemporary group, the radical cystectomy patients were older and had more comorbidities. There was reduced length of hospital stay because of ERAS. That's where this program, ERAS really centered from there. Dr. Brasangani came from USC and brought ERAS to us. The USC had increased use of robotic-assisted radical cystectomies, and they also increased their lymph node yield with the same template. So I'm going to run through some things that they found. So these are the trends that you'll see, number of days by year, and that the red mark is where they incorporated the ERAS program. You can see that their postoperative length of stage day has been reduced. I'm just going to run through a few of these different trends that they've had. Over this period of time from 1971 to 2018, you'll see that there was increased use of robotic surgery. And that was like maybe in 08, 10, they started doing robotic cystectomies. They said that they increased their lymph node yield up to, you'll see, by looking at a template program where they just go to different areas, and then that increased it up to 60 nodes on cases on the average. They looked at urinary diversions. You'll see going back in 82 was primarily ileoconduits. It was really in vogue at the time to have continent cutaneous diversions. The Indiana pouch was very popular in the 80s and 90s, but then really kind of incorporated orthotopic diversions. The Studer pouch in the early 90s kind of incorporated that, and so there was a lot of now orthotopic diversions. And then, but to the present time, you see it's kind of like has gone back to ileoconduits, less Indiana pouches, more Studer pouches, and those kind of orthotopics. There's been, now we're going to talk about their neoadjuvant adjuvant chemotherapy. There was a higher adoption of neoadjuvant chemotherapy by USC and a decrease in adjuvant chemotherapy. The neoadjuvant chemotherapy improved the complete response rates to PT zeros. So you see in this diagram and trends from 71 to 2018. If you go back in the early 80s, we were really trying to, urology in general, we were trying to figure out whether to do it neoadjuvantly or adjuvant in the 1980s. A lot of studies and confusion regarding that. But you see that neoadjuvant chemotherapy more recently has become more popular and less adjuvant chemotherapy. And that was their experience coming up to 2018. Any questions, you just stop me and we'll go over them. Now, if you look at this is the trends over time with the distribution of pathologic stage. And they made that point that if you look at the T0, M0s, the line at the more closest to the dates, that they have had more recently, and that was because of the use of neoadjuvant chemotherapy. But if you look at the other ones, you still see kind of it hasn't really changed much over time, has it? You still have the nodal metastatic disease at top, extravesical disease. The PT2s have kind of, I think, stayed stable and over time. I don't think there's been dramatic changes. Pathologic characteristics. There's been variant histologies have been seeing this really kind of as a wash. I don't think it really, but just some additional information for you. So the USC contemporary cohort, there was improvement in.
Would you be able to go back to the previous slide, Mark? There's a lot of information and
Sure. Yeah, anytime you want, if you want to start, Dr. Blasi, we can talk with this. I think I've given us more time to discuss issues in this talk.
Thank you, Mark. This is a great talk. It's just getting us a perspective for 50 years on a disease state. This is remarkable. Okay. The variant histology has been, I'm just wondering how much of this is pathologists calling these, and for some reason there's a downward trend for the last decade or so. Okay.
Move on.
Yeah, thank you, Mark. Yeah.
Yeah, so there's been an improvement in median overall survival in their contemporary cohort, but there has been stability in the recurrence-free survival. That's what they found. And if you look at extravesical nodal disease, the cohort, the T3As and 1s, the radical cystectomy outcomes were worse following a neoadjuvant chemotherapy compared to directed radical cystectomy. So if we see these with the T3A and 1, we should not give a neoadjuvant chemotherapy, they're saying, and go directly to radical cystectomy. So that's kind of an interesting point that they found. And we should incorporate. So this is the recurrence-free survival and overall survival in their series. And this is in the contemporary cohort. And so if you're really looking at it, there has been drop of overall survival, but the recurrence-free survival has been really a steady state. And so, but if you look at this diagram, then looking at the numbers of patient at risk, you can see that the disease has come back. With overall survival, you're down to a third of people at risk at 5 years. And this could be the overall survival from mortality from the bladder cancer, or it could be aging also. This is all going to be incorporated in that. And then the recurrence-free survival, the cancer comes back and you see it dramatically, but then the people at risk factors, look at, say that 695, I mean, there's just more people are dying from the cancer. So that's the reason why it's a flat line. It really kind of less people are at risk after 10 years. And then comparing the time, the numbers, if you look at the probability down at the right lower, you see that there has not been really a significant change from, I don't think, from the historical. So they have not made dramatic changes in recurrence-free survival or overall survival.
Hey, Mark,
Yes,
can I
sir.
ask you a question about that previous slide?
Sure.
Thank you for this overall view. It gives us such a perspective, really helpful. But I noticed there, for example, on the recurrence-free, on the next to the bottom line, that the 5 and the 10-year survival are so similar. And in all the figures that you showed initially with different classifications and different stages, it seemed like the 5-year and the 10-year survival were about equal. Now this bottom line doesn't show that, but like that. But it seems like the way the disease plays out in the first few years is what makes the difference. And if you make it to 5 years, then you're likely to make it to 10 years as well. And I'm reflecting on the just experience, I mean, my observation of how this disease plays out initially in terms of any delay in treatment, how it impacts survival. And the patients that I've seen that for social reasons or other reasons get delayed in treatment. Do you have any thoughts about this 5 and 10-year survivor? Is it really that stable as I'm seeing it here?
Well, I think we could have a brief discussion about it. If it comes back, it's coming back within 5 years, and they have that, and then it's really a flat line because you see that some people are affected by that cancer, some are not, but you still over time, you're still having mortalities from it in this.
Mm-hmm.
And so that's what the recurrence, it can be cancer coming back, but also could be mortalities are also affecting us also, and then overall survival over time. So, but it's really,
Okay.
they have not made any significant changes. Any other comments?
Thank you.
Then if you overall stratified by pathologic stage, you see the best are the T0.
I was just going to make one more comment on to follow up on Roberto's question.
Yes, sir.
So, one of the things we're exploring in with our research associates is what we call adaptive management. In other words, there's a question, how frequently do we need to follow patients up, how long, and so on and so forth. In addition to looking at overall outcome, these curves, we are trying to pay more attention to the shape of these curves as much as to the actual numbers on the y-axis or on the x-axis. So if we look at it here in theory, most of these patients recur within 5 years. So that's when we have to monitor these patients closely. And if somebody doesn't recur in that time, the chances of recurrence is less, and therefore we can follow them up less frequently. And this does have implications in terms of healthcare cost and patient convenience and so on and so forth. So I think as we move forward, paying attention to the shape of these curves may also be as important as just looking at a landmark, at 5 years what happens or at 10 years what happens.
Yes, and
Just a thought, Roberto.
Thank you, Dr. Willage.
yeah, and again, everyone, this is just the post radical cystectomy cohort. Okay, this is just surgical intervention at this point in time. Okay, then overall survival stratified by pathology. The best is at T0, N0, the top green line you see, and then you see how the differences in curves, as you're suggesting, Dr. Balaji. So you can see with the T2s. In that center aqua line going down, but then extravesical nodal metastatic. See, their overall survival is taking a deep, it's all happening there very quickly, isn't it? Less than 5 years period of time on their reoccurrence. But you can, the point I think to make in this one also, if you look at again the T2s where you think you've really taken their bladder out, they've made their sacrifices, but their survival at 5 years, I don't know, it's maybe looking at like 75%, like 25% of even the T2s are losing their life and after the surgery. So
Hey,
there's
Mark,
work to be done.
I don't want to tie up too much time, but in this table, it does look like a big difference between the 5 and the 10-year survival in most of the categories there. So it looks a little bit different than the initial slide that you had shown. It was just a curiosity I had. Thank you.
No, well, this is now we're breaking this up. It's really stratified by pathology. So you're going to have those differences. That previous slide was all, the entire cohort. So this
Okay.
really divides that up into by pathology
Thank you.
after surgery. Yeah, you're welcome. Then recurrence-free survival by pathology also is, and you can see that there's a significant differences between the T2s and then extravesical nodal metastatic when they're stratified by pathology and recurrence-free survival. So now I'm just looking at the historical versus the contemporary just to see the differences. And frankly, if you look at their to the left is are two tables on the contemporary recurrent-free survival and overall survival. It's really been stable over time. And and then comparing it with the historical. So I don't think there's been that much differences in because of their surgical technique. And that's the whole point of this talk, is that. So the limitations in this was retrospective analysis. They did not have patient performance metrics or comorbidities. And also this analysis predates the use of checkpoint inhibitors in the urothelial carcinoma bladder management. But they said that some of their conclusions, they adhere to urologic sound surgical principles to providing a consistent outcomes. But there's a subset of bladder cancer patients who derive a benefit from the neoadjuvant chemotherapy. However, they need to identify the non-responders to neoadjuvant chemotherapy. And there's a need for novel therapeutic intervention. And then they also really identify that for the extravesical node positive, that's a need for early radical cystectomy. So now I really want to dig down into neoadjuvant chemotherapy, and this is what they've done. And if you I kind of like this looking at times on the left, from 71 to 18, and then they started incorporating. You can see the neoadjuvant chemotherapy, the number that's admitted that had administered in that all down at the bottom where there is a non-administration. And if they look at there, they use neoadjuvant chemotherapy about 21% of the time. And because of that, there is some adding to, now if you look at the far right, the pathologic stage, they're adding to the T0, they're adding small amounts to the organ confined, but there's still, if you look at it, there's still a larger group, even with neoadjuvant chemotherapy, that pink line, extravesical nodal metastatic disease seems to be the biggest. If you look at the volume, that tells you of the line is also the volume of patients. Without, this is now not administered. So no neoadjuvant chemotherapy. This is their findings. And everything is significantly different if the recurrence-free survival at the green, if you're looking at B, the green is there's the key down at below. The green is the T0, N0, M0. Blue is the organ confined, extravesical. They're all significantly different from recurrent-free survivals. And then if you look at on the overall survival, there's significant difference between the T0s and the organ confined and extravesical nodal. This is no chemotherapy, neoadjuvant therapy. So there's no difference in recurrent-free survival by an organ confined, but there's a significant difference, better than the extravesical and nodal metastatic disease group. So still the extravesical nodal metastatic pathologic stage really has the worst prognosis by relapse-free survival and overall survival. Again, we're keeping this group in mind as we're going through this. Now, with administration of neoadjuvant chemotherapy, there are some changes, not so much on the recurrent-free survival. You see that there's a significant difference. It helped the T0 and organ confined. And it also, you see differences in overall survival also that neoadjuvant chemotherapy has helped. But still the extravesical nodal metastatic stays in the basement there on both of these curves. In this table, if you look at the whole point of this table, that with clinically outcomes, if you have the clinical T2 or greater, they have no benefit to having, and if you see the upstaging at cystectomy on that bottom, they have really no benefit to having neoadjuvant chemotherapy administered. So it's better to go to early radical cystectomy rather than neoadjuvant chemotherapy in this group. So I want to now compare the USC group to Memorial Sloan Kettering comparison, another high volume academic center, and they know how to do radical cystectomies there. So if you look at the contemporary group, there's really stability in 5-year recurrent free survival, 65%. However, Memorial had a different experience. They really found improvement in their 5-year over time, with improvement from 58 to 66% from 1997 to 2013. So why is that? So we're looking at what are these differences? The reason for differences is it because of robotic surgery, pre-op and neoadjuvant chemotherapy, or pre-op the cohort clinical stages. And so this is the article from Memorial, and this is the similar series of between 1995 to 2015, where they're looking at the differences. And they found that there is a declined 5-year probability of disease reoccurrence from 42 to 34%. There is a decline in 5-year probability of cancer-specific mortality from 36 to 24, both significant. And with these curves, you see they had improvements in disease reoccurrence. That's A. B was death from bladder cancer, and then death from other causes. There wasn't any really change in their clinical stage. That really kind of was a flat line from 1995 to 2015. So it wasn't that they had these improvements. But this is what they did. They increased their rate of neoadjuvant chemotherapy. And this, if you look at the rate of chemotherapy use, really goes up to, really, they said 57%. And that's going to 2015. So they really incorporated neoadjuvant chemotherapy much more than USC did, from 57% in Memorial versus USC was 21%. And because of that, there was an increased rate in the T0 pathologic stage group. They also had a reduction in positive margins because of the neoadjuvant chemotherapy. So conclusions, there's a decrease in probability of reoccurrence in cancer-specific mortality at Memorial. They were optimizing both surgical and perioperative care. The contributing factors were increasing the use of neoadjuvant chemotherapy, 57%, which increased their T0 rates. They increased their lymph node yields and had decreased surgical margins. If you look at a P, complete pathologic response, is a metric that's strongly associated with overall survival and recurrence-free survival. The complete pathologic response is considered a surrogate endpoint to evaluate for treatment efficacy. And if you look at neoadjuvant chemotherapy administration, is increased with a T0, M0. These are different series. This is the USC series, Memorial series, and then the final thing was from a final line is multiple international centers had a 22%. So really similar. This was a meta-analysis. Well, they're actually looking at stages from in 2015. So quite similar. So now what we're finding here, I'd like to now kind of stop and kind of make some summarize. Management of bladder cancer really has become a team sport. This is no longer is a radical cystectomy considered alone for the standard of care. So when we're doing those cystectomies, it's just part of their care. We must incorporate both neoadjuvant and adjuvant systemic therapy. And because think about it, that early stage T2 muscle-invasive bladder cancer, almost 50% with curative radical cystectomy relapse, 50 to 60% overall survival in 5 years. So we need something else. We find so far, though, that it's valuable to have neoadjuvant chemotherapy. It's doing something. But the problem, pathologic stage group, is the T3 plus and the N1 plus. We need a novel therapy, and that's what we're going to look at now. So this is a meta-analysis in 2005, which was where they really looked at the benefits of neoadjuvant chemotherapy. I'm going to probably need to pick up the pace here. This 2005 meta-analysis was all eligible randomized controlled trials comparing neoadjuvant chemotherapy with surgery alone. It was like 11 trials, 3,000 patients. There was a significant survival benefit associated with platinum-based combination therapy. The hazard rate was 0.86. This is equivalent to the 5% absolute improvement in survival in 5 years. There was a significant disease-free survival benefit associated with platinum-based therapy, and equivalent to a 9% improvement over 5 years. So in 2005, these results provide the best available evidence supporting neoadjuvant platinum-based chemotherapy. And if you see this forest plot, which you guys are familiar with, that the neoadjuvant chemotherapy all had better hazard ratios. And this was with a group of different randomized control studies. Grossman from that other medical center, MD Anderson, had one of the early papers on this. But this clearly shows the benefits of neoadjuvant chemotherapy. And you see the absolute survival benefit. This is the information Dr. Balaji has shown us also, but there's an improvement in overall survival from 45 to 50%. That's the reason how he mentions the survival benefit of 5%. What are the challenges, though, with neoadjuvant chemotherapy? And that's where we can't give this to everybody. Because of that, there's low utilization rates. There's eligibility restrictions due to toxicity, myelosuppression, neuropathy, nausea, vomiting. There's patient factors that are a challenge, and we can't give it to them because of impaired renal function, their comorbidities, they're concerned for toxicity. And also, can't get into the details now, but these tumor cells develop resistance to cisplatin. Also, we're lacking biomarkers to predict therapy responses and stratify patients better. But still, with this, there's inadequate therapy for T3As to T4s and positives. So cystectomy is not sufficient. Approximately 50% of patients who receive standard treatment for muscle-invasive bladder cancer, that is, neoadjuvant chemotherapy with radical cystectomy, have reoccurrence within 3 years. So even with this, neoadjuvant chemotherapy is not enough. Because of this fact, this promoted the use of a perioperative nivolumab to clinical trials. So now I'm going to go into these clinical trials here. This, it was in So this is a perioperative durvalumab neoadjuvant chemotherapy following cystectomy. And so their cohort was a group of T2s. This was over 1,000 patients. Clinical stage was T2, T3, 4A, and with or without positive. They had operable, muscle-invasive bladder cancer. They were eligible for cisplatin chemotherapy and had normal renal function. And this was their trial design. And so if you look on there's 533 patients had nivolumab. They had gemcitabine, cisplatin, so chemotherapy with durvalumab. Then they had radical cystectomy. Then they had adjuvant durvalumab. And that was compared with the neoadjuvant chemotherapy and surgery alone. So this is the comparison, okay? The event-free survival at 24 months was 68.8% for the durvalumab group and 59.8% in the comparison group. And you can see those Kaplan-Meier curves and the differences. And if you look at the forest plot, it's a benefit to durvalumab versus the standard neoadjuvant chemotherapy and surgery. There was one criticism with this study, though. They could have broken up the two groups and divided. So, and they could see they don't understand because of this, the contribution of each. It wasn't the durvalumab with chemotherapy prior to, as neoadjuvant, or was it the addition of durvalumab as adjuvant therapy? That would have been a benefit to this study. Overall survival was improved in this group with durvalumab versus the neoadjuvant chemotherapy. And overall survival also, you can see this was better with use of durvalumab. If you look at the adverse events, they're really comparable. The grade 3 or 4 adverse events were quite similar. So their conclusion was in cisplatin eligible patients with muscle-invasive bladder cancer, perioperative durvalumab in combination with neoadjuvant chemotherapy and surgery improved survival outcomes as compared to neoadjuvant gemcitabine cisplatin radical cystectomy alone. And I believe that, so this is if you look at this neoadjuvant chemotherapy, systemic therapy, so you have neoadjuvant chemotherapy if they're eligible, and then you can have sandwich therapy afterwards. Is another alternative for neoadjuvant systemic therapies. I'm going to switch to adjuvant therapies now. If you give the neoadjuvant therapy preoperatively, then if you look at top line, you can use a durvalumab postoperatively. If there's no cisplatin neoadjuvant chemotherapy, then that's when and it's like, and it's a T3, T4 problem, a pathologic stage, that's when you can use the adjuvant cisplatin chemotherapy. And also then consider the checkpoint inhibitors. So we're going to talk about this now. So adjuvant therapy they're switching to. So if you have not had neoadjuvant chemotherapy first and they're able to, it's still preferred to give the neoadjuvant chemotherapy afterwards. Or else now we go into combination therapies with nivolumab and pembro. This is a meta-analysis showing the benefits of adjuvant chemotherapy if we're able to. This is a recent article in 2022, and it investigated the role for adjuvant cisplatin-based chemotherapy. They looked at 10 randomized control studies reviewed and did the meta-analysis. And you can see in this group, I want to point out there's the fine details on the right, but I took them out that this was really a balanced pathologic stage treatment and control between the two. And this was heavily, in this cohort, had the T3s, the T4As, and the N1. So you could add that up, that it was really 2/3 of the cohort had the extravesical node positive disease. And they found that there is a benefit of the adjuvant chemotherapy in overall survival. The absolute improvement in survival is 6% at 5 years, from 50 to 56%. Then there's a 9% absolute benefit of overall survival when adjusted by age, sex, stage, and PN category. You could see in this forest plot the overall effect on overall survival in these randomized control studies. Adjuvant chemotherapy, overall survival was improved. So adjuvant chemotherapy should still be used. You have to continue to use cisplatin-based chemotherapy afterwards. The recurrence-free survival had a benefit. Local regional recurrence-free survival was a benefit, and also metastases-free survival. You see this in this Kaplan-Meier curve, the effect on recurrent-free survival and effects of local-free survival and metastases-free survival. But neoadjuvant chemotherapy, followed by radical cystectomy, is the standard of care for muscle-invasive bladder cancer therapy. However, 1/3 of these surgically treated patients did not receive or decline neoadjuvant chemotherapy, or they had persistent muscle-invasive bladder cancer after neoadjuvant chemotherapy, or else they were unfit for the neoadjuvant chemotherapy. So this is where we can't use the chemotherapy. So then now this is how we're incorporating now the checkpoint inhibitors, and that is the pembrolizumab. It was approved for a carcinoma therapy. So this is a study that demonstrates the benefits of using pembro now in the adjuvant setting. And this is a New England article, adjuvant pembro versus observation. They looked at muscle-invasive cancers after surgery before the trial. And you can see the pathologic stage, and this was also the extravesical and positive group that we identified early on in the two studies from USC. And so in this study, the trial design, these are patients with muscle-invasive bladder cancer after radical surgery, with or without neoadjuvant chemotherapy, and they were given adjuvant pembro or observation. Pretty straightforward. And the results were that the disease-free survival was 44.8 months for the that was the median follow-up, but pembro had a 29 months median-free survival versus 42.2. Oh, excuse me, a 14.2. You see that in this curve, the differences that the improvement that pembro had versus observation. The disease-free survival was better with pembro, 29.6 to 14.2. And also in this group, this was a group with extravesical disease. You could see a 50%, 42%. So this is incorporating that group that we now have therapy for. Adverse events were minor. So among patients with high risk muscle-invasive urothelial cancer, disease-free survival was significantly longer with adjuvant pembro than observation. So this is how this study really brought adjuvant pembro into this space to take care of the T3 extravesical and node positive disease. One more study is the nivolumab with gemcitabine. The problem here is that the platinum-based chemotherapy, it is the standard of care for untreated, unresectable, and metastatic urothelial cancer. But cisplatin-based chemotherapy, sorry, I'm dry, is preferred for eligible patients, but the durable responses are uncommon. So it has only its limitations. So that's the reason why now using a checkpoint inhibitor is necessary. So this is a new agent. Nivolumab was utilized to improve the overall survival when you added it to the chemotherapy. So now we're still using chemotherapy, the benefits of it, but it needs a checkpoint inhibitor to help it. So this is a phase 3 study, multinational, randomized control, investigating nivolumab, an anti-PD-1, to gemcitabine cisplatin, improved outcomes in adults. So in this study, here's the trial design. They added nivolumab plus the cisplatin-based chemotherapy versus the cisplatin-based chemotherapy alone. And it's really like a one-to-one design. They found they had a median follow-up of 33.6 months. Overall survival, progression-free survival was significantly longer in the nivo group. And you see that in this Kaplan-Meier curve, overall survival was improved. And so what we're really doing is giving now adjuvant therapy that's really helping out the surgery groups that we've seen before. The progression-free survival was also improved. So in conclusion, patients with previously untreated, unresectable metastatic cancer, now we're adding a combination with nivolumab plus the cisplatin, improved overall and progression-free survival outcomes as compared to cisplatin therapy alone. So in conclusion, we've now incorporated immunotherapy. I hope this explains the problems that we have with surgery alone. And the problem group that we have is the T3, a T4A N+. But now we have adjuvant immunotherapy that will help us in this high-risk group. So if there are indications for adjuvant immunotherapy are the ones that, say, if you have a T3, T4A N+, it benefits them. Also, the high risk who did not receive cisplatin chemotherapy, either as neoadjuvant chemotherapy or adjuvant chemotherapy, if they had low comorbidities of poor renal function, they cannot receive it. This is another space that adjuvant immunotherapy can help. And it's that group also, see if you had previous cisplatin-based neoadjuvant therapy, but you have that persistently high-risk features afterwards. You've given them surgery, you've given them a chemotherapy, but they still have the YPT2 4A plus and plus with nodal disease. This is another space for adjuvant immunotherapy. And that's it. So that's kind of an update that I try to give everyone and kind of put this together. But we just keep marching on with taking care of these patients, and there will be new therapies, new ways of doing this. An example is the infertumab and Pembro is just another step forward in treating these people. Thank you. Any questions?
Great talk, Mark. Mark, I just had one question with regard to adjuvant nivolumab. Now, there is a study that looked at nivolumab alone, is that right? Because the study you showed was not necessarily an adjuvant setting. This study is anybody with unresectable, locally advanced or metastatic, where you do nivo plus gemcitabine, and that's better than just doing gemcitabine alone. Was there another study we just looked at adjuvant nivolumab similar to adjuvant pembrolizumab?
I could have missed that. It's just time restraints, but I could look that.
Yeah.
I don't know to answer your question, sir.
This is a great talk, Mark. We're able to put a historical perspective, and there's still a little bit of lack of clarity, Mark. Our intuitive thinking is if somebody we suspect have locally advanced disease prior to cystectomy is to proceed with neoadjuvant chemotherapy. whereas the USC data tells us the opposite. If it's locally advanced, proceed with cystectomy first because neoadjuvant may not be as effective. So that's a decision we need to make. And a lot of these neoadjuvant studies were done in a time when the adjuvant therapy was not as effective. Even when you looked at that meta-analysis curve, a lot of those adjuvant studies were negative, but ultimate meta-analysis showed there is some benefit to it. But now we have more effective therapies for systemic disease. So then the question of neoadjuvant therapy in that setting. So
Yeah, I think that was I agree. That was their thought at that time. But now if you really look at it, see that last slide, using adjuvant immunotherapies or you would use those, which they didn't have at that time. So, but that was like their conclusions in that one table.
yeah. So Mark, if we have a patient, say, with what we think is a T2 disease, with undergoing a cystectomy, should we give neoadjuvant chemotherapy to that patient?
I think so. I really think so. If you really look at the memorial study, I think we're underutilizing it here. I know that there's that 5% overall survival, but you have to really look at the relapse-free survival data and Memorial's data on so I think if we have that healthy 50, 60-year-old, I think we really should be using the chemotherapy neoadjuvant.
Yeah. And if we do that, then the therapy of choice would be Gemcis and durvalumab.
Yes. Now I didn't have time. There's the dose-dense MVAC that showed it was really kind of equivalent. I've seen in this one meta-analysis between the two of them. But I think, for us to give the Gemcis here, it's in 4 cycles. And if we have a great system, you've created a great systemic therapy program, I think I would go for neoadjuvant chemotherapy first.
Yes. And if somebody had non-organ confined disease clinically marked on the MRI and things that we do, should we then give them neoadjuvant chemotherapy?
I think so. If you have, again, a young person and the benefits from that, because that data also really showed, and that was old data from 2005, really showed the benefits of that also. So I think if we have the ability and they're willing to have it, I would do that.
Yeah. We have not been doing dose-dense MVAC here because it requires growth factor support and so on. So, but that's something we could consider. We haven't done that. We are doing Gemcis and immunotherapy now in this.
I don't think so. I don't think we need to. I don't think we need to change that because of they tolerate the Gemcis.
Yes.
Well, you know better than I, but I looking at them, and so I've in some index cases you see that they really do benefit from it.
Yeah. Any other questions or comments today, guys? Questions for Dr. Bandyk? Mark, as always, if you wouldn't mind sharing your slide deck with Melanie and send it to us, it would be great. This is, again, I keep saying, God's slide deck.
No, thank you. Thanks for the opportunity. Thanks, guys.
Thank you.
Thank you, Dr. Bandyk.